Hi, everybody. Thanks for being here. Welcome. I'm really excited to see faces I know, but faces I don't know. That's exciting. So, welcome. It's great to have you here. I'm Cecilia Shelton. I'm an assistant professor in the Language, Writing, and Rhetoric area group of faculty here in the English department. And I'm really excited about the very first event in our speaker series today. And a lot of things are coming together. So, Dr. Molly Collins is going to be our guest speaker, and she's been with us for the first hour of my graduate seminar, which is about Black feminism as methodology in rhetoric and writing studies. And the Language, Writing, and Rhetoric group of faculty are co-hosting this event with the Digital Rhetorical Privacy Collective. Those folks are Zooming in, so welcome to my DRPC friends. I don't know where I'm looking, where the cameras are, but hello. I think that Dr. Chen Chen is in the chat as a representative of our group, and she can drop a link if you're curious about the kind of work that we do. We've been doing events all week for Privacy Week, and there's been some great conversations, including another one that's happening tomorrow. So I'm sure she'll drop some stuff in the chat, more about that, checking out what we do in general, but also about that event tomorrow. And so we are excited to co-host this event, and we're really grateful to the Center for Literary and Comparative Studies and to the Frederick Douglass Center for Leadership in the Humanities for co-sponsoring the event. So lots of people interested and invested, and I'm really grateful. And so I will now introduce our speaker of the hour and make space for her to get started. Dr. Molly Collins is an assistant professor of African American and African Diaspora Studies at American University. Her research areas include Black motherhood studies, Black archival studies, 20th and 21st century literature and art, medical humanities, digital technology, and reproductive health and justice. She is a practicing birth, postpartum, and pregnancy termination doula, and a trained perinatal and infant loss advocate with the Womb Room in Baltimore, Maryland. Prior to joining CRGC, she was an assistant professor of African American literature in the English department at Howard University. Her creative and peer-reviewed work has appeared in American Quarterly, Souls, a critical journal of Black politics, society, and culture, National Political Science Review, and The Black Scholar. Her first book, Scrap Theory, Reproductive Justice in the Contemporary Black Feminist Imagination, will be published in late 2024 by Ohio State University Press. Please join me in welcoming Dr.
Thank you so much for the intro. Thank you again to Dr. Shelton and Dr. Wilder for organizing this, and also the admins making this possible. I also know I have a lot of people from around the country who are actually in right now, my family. I don't know where I'm looking, but since it's Privacy Week, I guess we should look everywhere. The cameras are everywhere. So there are people probably on Zoom and maybe here who can't see me. I'm a light-skinned Black woman. I'm very tall, wearing all black. I have glasses on, and very bright blue nails. As Dr. Shelton mentioned, I'm a professor at American University. I don't want to continue to talk about my book. I'm not gonna lie, y'all. I could give you the synopsis again, but I think what would be more interesting for us today, given all of the interest, especially of hopefully folks in the room, is if I can really center my work on Black women's 20th and 21st century literary and visual creative production, which privileges the body, visuality, and materiality as archival documentation of Black mother-child separation, and really make the through line between the book and the work that I'm doing now, which is fundamentally connected by the axiom that Black reproduction in general calls for a renegotiation of scholarly relationships to information, history, and memory, and the presumed qualifications of what makes a documenter or an archivist, and what constitutes documentation or something to be archival matter. So simply put, Black feminist approaches to memory work create an intertextual production of memory, time, and space to scale the meaning of what I call scraps of food, fabric, and even our bodies as foundational to Black memory work across disciplines. So just a few notes before I get started. I want to mention a trigger warning. I am talking about the Black maternal health crisis. I will be talking about birth violence, and specifically describing a medical procedure that's done on a uterus. I also want to note that I use terminology in this talk, the terminology of Black women, right, and Black pregnant people, and I use that interchangeably. But I want to, of course, note that I know that these experiences of non-binary people and Black cis women cannot be collapsed, right? I do this instead to really encompass kind of this experience of what it means to carry a child. And just simply put, again, my methods now and forever begin and end with centering Black folks and their bodies as a unique paradigm to understand the past as well as the future for Black children. So let's start by naming the primary crisis that I'm going to talk about today. And again, I'm specifically talking about the Black maternal health crisis, which is actually a fairly new phrase, speaking of rhetoric. It's one that first publicly appeared in 2018, and it was used by then Senator Kamala Harris and North Carolina Congresswoman Alma S. Adams. They introduced a legislation at the time to recognize the inaugural Black Maternal Health Week that of course was successful. We have it now in the month of April. And in their legislation, right, in this call for why it was important to have this health week, they cited an article that said, quote, from the year 2000 to 2013, the US experienced a substantial increase of 26.6% in maternal mortality rates for Black women. And according to the CDC, Black mothers in the US die at a staggering 3 to 4 times that of the rate of white mothers. Black women are also twice as likely to suffer from severe maternal morbidity than white mothers, end quote. And so what you see here on this slide is a graph of the CDC study that was released. And you can see that this was actually released, or these account for percentages of 2021, right? I understand we are now in 2024. So you may be wondering what's going on now. It's actually up 70% since 2021, okay? So this statistic of 3 to 4 times more likely is actually quite outdated, even in the year of 2024. So again, this last time I'm gonna throw numbers at you. In 1999, we saw 505 Black maternal deaths in the US, okay? In 2021, we had 1,210, okay? So what has occurred since 1999? Of course, there's an array of geopolitical issues, social issues, everything under the sun, right? But what I wanna talk about today that I kind of see as a concomitant development is the popularization of cell phone use, internet usage, and the access to apps, online media-based, social media-based support groups, and also the upward trending of medical technology use in the birth room. And so I think it's really important now to ask direct questions, especially in this 70% increase in these last couple of years, about the renewed pressures on Black people's reproductive rights in the digital age, and the overlay between the right to fair use of medical technological devices and our right to reproductive choice. And by fair, I mean equal, safe access, free from surveillance and data mining. I'm speaking a little bit to the students in the room, but I hope that this is a call for everyone. Of course, in ethnic studies, we must evoke our research from the actual praxis of working with people who are affected and re-affected every day by such crises that render life and death scenarios. So it's our family, it's our fictive kin that are really the impetus for our work, hopefully, and I know it is for mine. And it ties all of my work together, right? So I want to situate the genesis for this project in a personal experience that really illustrates how Black reproductive life lays bare a bevy of personal liberty violations, which are particularly exacerbated in the times of crisis. So in 2015, my sister became pregnant with our first family baby, Queen Aziza, who I think is actually on the line, so hey Aziza. And I asked my sister when she became pregnant, I was like, so what baby books are you reading, right? What's going on? And I received an answer that I often receive from people that I teach now in childbirth education groups. And my sister said, I don't read baby books, I read baby internet. So again, this is a common response, and there are other factors that go into just, oh, we live in a digital age, so everyone gets everything out their phone, right? And I think it's because technology allows Black women like my sister to mitigate traditional medical experiences that are statistically more likely to leave us uncared for. My sister's logic is actually supported. It's evidenced by a study that says that 21% of Black women who say that they've actually experienced microaggressions with their OBGYNs, and those experiences make them not want to go to their doctor's appointments. So for many Black women, there's no use in reading a physical book or talking to a condescending provider when they could just do a quick search for an answer online or have an app that tells them exactly the size of their baby on any given day. Avoiding providers is worth the risk of this pregnancy for them, and research suggests that this is common, and it's partially responsible for why we have early death rates, right? There's a stigma around seeking medical care, and of course, Black community distrust of doctors. We are often willing to risk death rather than work with a bad provider, or in the case I outlined above, even read a book that's recommended by them. So I'm still curious to understand how, in our new age, people are learning to separate medical technology apart and separate from racist medical providers, rather than seeing the technology as an extension of these racist practices, especially since Black people's bodies and technology have a historically fraught relationship. Journalist and scholar Harriet Washington has done a lot of this heavy lifting to expose the work of Black bodies and how they've been continually used to make groundbreaking health advancements for others and at our own detriment. Here, I want to highlight exactly 14 Black men who died in the year of 2004 from the experimentation of artificial battery-powered hearts in Michigan, and also to the synthetic blood which was and is still non-consensually injected into the bodies of emergency room admittees in Detroit and Flint, Michigan. This study specifically with the artificial blood has about a 30-year experimentation period, and it's still ongoing. And of course, everywhere here in Maryland, everyone knows of Henrietta Lacks and her HeLa cells, which were unethically mined from her body and specifically for cervix by Johns Hopkins University. And you can see artist Kadir Nelson's image of Miss Lacks here. So medical experimentation is crucial to further developing tools to innovate new practices of care and hopefully keep everyone healthy, right? Yet technology as a field often evades discussions of racism and sexism, even though scholars have proved repeatedly that technology does not eliminate bias. When technology is routinely tested on Black people without their consent, the products from that experimentation can never adequately treat Black folks as humans. It also cannot treat Black people as creators of valuable life, making medical experimentation something that threatens one's reproductive autonomy as well. Iterations of reproductive violence not only include medical experimentation on the reproductive system, but historically is actually much more capacious. And it spans out to unwanted sexual contact, to the inability to choose one's sex partner, the long history of wet nursing, and anything that really violates one's ability to raise their children successfully into adulthood. Historically, Black women's reproduction has meant different things to the institution of slavery, and the captors that upheld it, right, were sometimes deemed producer, breeder, or liability. And the denial of Black women's humanness produced bodies categorized by our sole ability to be caretakers, mammies, and other domestic workers to white children. And of course, these tasks required Black mothers to forfeit their time with their own children. Black women have experienced all these violations and more while being routinely subjected to medical tests. Medical historian Deidre Cooper Owens' work exposes early 18th century physician J. Marion Sims and his role in developing the modern field of obstetrics and gynecology, especially on the bodies of enslaved Black women and Irish women in Alabama. In one case, he performed a procedure called a fistula repair on an enslaved woman, or I should say child, she was actually 14 at the time, named Anarcha. He performed this over 30 times without pain medication, and his contemporary, John Peter Mettauer, was heralded as the first to use lead sutures in a fistula repair. And here you can think of like making a stitch, but with metal, and now we still use staples. While both physicians created multiple operational techniques, they also created the foundation for how gynecology and obstetrics would continue to discuss and treat Black women in general. Sims has written on record flatly that, quote, Black women don't feel pain, end quote. And Mettauer blamed one of the people he experimented on for having, quote, an over-sexual appetite for the reason she would not heal after his multiple medical intrusions. Thus, the terrorism against Black reproduction is the source of many racially based myths in obstetrics and gynecology, which still say that Black women don't feel pain, and also that Black women have too much sex and have too many babies. Enslavement, and the way it allowed medical experimentation as part of an institution, gave breath to the stereotypes still prevalent in the medical community around Black women's sexuality and our relationship to pain. So it's important to place Anarcha's pain within the genealogy of the emotional archive as well as the medical. Of course, I as an individual cannot speak to the amount or the kind of pain she experienced, and I also know that only encountering documentations of medical abuse under the conditions of erasure leads us to find them revived in different forms for their descendants, especially in the experiential artifact that we now call intergenerational trauma. As such, we know that we cannot simply signal a recovery project here for Anarcha and the subjects like her, because they can or must be saved from their meeting with violence. Nevertheless, a more paradigmatic approach to violence and information confronts the ways that Blackness often becomes immaterial for readers engaging with racially fraught histories. In the body, archival material of our ancestors' violations can never be lost in the afterlife of slavery. Yet and still, we can look toward material art to challenge the normative conceptions of artifact, data, and information. It's art and materiality that challenges notions of archives of reproductive violence by interrogating how these texts bury their own historical truth when they position their subjects as merely representational, rather than visceral samples of the texture of Black people's lives in the past and in the present. So, sculptor and artist Doreen Garner takes this charge literally in her resculpting of a J. Marion Sims statue that until 2017 was in Brooklyn, New York, and it was on a pedestal. Before its relocation, we'll say, its relocation or its tearing down in a cemetery in Brooklyn, and then it was put in the Hudson River. Garner took a 3D scan of this statue and created her own of it, painting it red. It's made out of rubber. And in the images here, you can see her creation of this statue. So shortly after its creation, she staged her own exploitative, dehumanizing yet intimate encounter with J. Marion Sims. Her 2017 performance piece of White Man on a Pedestal recruits 6 Black women and non-binary people to take the silicone replica of her making to an open surgical room. Garner's lifelike blood, muscle tissue, and tendons, which again are made of rubber, Swarovski crystals, and pearls, as well as staples, as an homage to Mettauer. This helps her stage her own fistula repair, and then with help from her surgical assistants. It's also about a 14-minute performance piece, and it's online, so I highly recommend it. In the stills here, you can see the operating body, see them operating on the body, and Garner instructing them to slap it, cut it, and stab it. An endoscopic camera is pushed into the statue's interior so the audience can watch the abrupt and brutal reproductive surgery. Of the performance, Garner says, quote, "As an artist, I'm horrified by these actions that she performs on this sculpture. But it's not a situation where people can overlook this information anymore," right? And she's speaking there of the Black maternal health crisis. So the information that she presents as documentation of Anarcha's experiences do not remove the injuries done onto Anarcha. Instead, this piece reappears the information Garner believes is so easily ignored. Black reproductive life has been made expendable for the medical benefit of others. Black folks' material use with medical technology, such as the endoscopic camera, has been historically perpendicular to their betterment. An artistic approach to technology and public health intersections can lead us to imagine technology as inherently different used for and by Black people in an age that reimagines reproductive violence inherited by its perpetrators as well as its victims. So I want to share one specific instance of this evolution of different use of a specific medical device, which is the fetal monitor. So this is a photo taken by Robert Galbraith, who is a mid-century photographer. He actually followed midwives in the South for a couple of photo series projects that he created. This is one of midwife Mary Frances Hill Coley. She lived from 1900 to 1966. She's a Black midwife from the American South. She was a very well-respected midwife on the order of what we call granny midwife, or someone who provided prenatal, labor, and birth care without formal medical training at all. And we have here in one photograph from this series, he also has a video documentation of this birth. But from this still here, we can see that she is leaning over a bed and she is gently touching a mother's belly who is slumped. The mother is clearly fatigued and defeated to the unpredictability of birth. Candlelight illuminates the right side of Hill Coley's face while the left side of it remains unexposed. Her nonplussed expression indicates that the haptic message she receives from palpitating the top of the woman's uterus is inconclusive. The baby may or may not soon come. Unable to fully see the face of the expectant birthing person, nor that of Hill Coley's, we, the audience, can only hope that everything is progressing the way it ought to before the delivery of a healthy baby. Leaving many questions unanswered, we can only infer the status of the birth and the mother's health. Thus, the photograph is aptly named, untitled, Patiently Watching. Interacting with institutional and artistic artifacts together helps us kind of undo this epistemic violence that comes with articulating what Christina Sharp calls the method of encountering a past that is not yet past. So encountering medical technology in the creative archive of Black women means encountering an entire history of Black care, which does not always demand that every instrument or tool be renovated. In Hill Coley's time, her hands were the device through which she communicated with her client's baby. She gauged the baby's position by palpitating the uterus with her hands, if necessary, and timed contractions by the pitch of the birthing person's moan, right? If you've ever been present or if you've had a baby, the lower the moan, the sooner the baby is coming. So time was no variable for birth for granny midwives unless you hit maybe the 3-day mark, the 5-day mark if you're a first-time mom, with an exception that if you had a fever spike. But birth simply took as long as it took, and contractions were noticed rather than regulated. Today, in a hospital setting, patients are only visited usually once an hour by a nurse to check blood pressure and temperature, and a midsection monitor, which you can see on the left-hand side here, details the messages of the contraction to the nurse's station screen outside the birthing room and in the hallway. Rather than a provider touching the belly to feel the strength and timing of a contraction, the midsection monitor stands in for the person-to-person care of a provider. The midsection monitor appears to give freedom of movement for the pregnant person, but it actually limits it and necessitates more supervision in the long run, because a full reading is best received when the person is either on their back or completely still. This position is contraindicated for safe and shorter labors and often accounts for the deceleration of a fetus's heartbeat. So today, in many hospitals in which I've supported people, many people don't actually meet the provider who will be delivering their child until minutes leading up to the baby's emergence. OB units work in shifts and birth is climaxed at the delivery. The baby requires medical presence, not the birthing person. Actually, I'm gonna go back to this. A midsection monitor does not record, I just want to be clear, a midsection monitor does not record the strength of the contraction, right? That's a really odd measurement. It actually is measuring the acceleration of someone's heartbeat, of the parent's heartbeat, and the deceleration, which is down here. This is my son's record. This is my heartbeat down here, and this is his. So you can see whenever mine goes up and I'm having a contraction, his is actually going down, right? So, so it doesn't actually record the strength, but rather the deceleration and the acceleration that come with the contraction. is the uterus presses down. The uterus muscles are not, they're actually like a baseball, it's a sphere, right? So everything's pushing down intensely. The use of something like an epidural, which is a spinal anesthesia, actually makes everybody's heart rate go down, right? And that's not necessarily always something for an emergency, right? Everyone's heart goes down when you're more relaxed, right? That makes sense. But sometimes the heart can decelerate beyond the comfort of a provider, makes sense, especially if one is given medications to make labor move faster, right? Because you've had your epidural, so now everything's too relaxed, so now we need to hurry contractions up again. We use Pitocin or Cytotec for that. And then the uterus works more intensely, okay? So this then creates kind of this feedback loop that causes alarm, and it necessitates crisis-like attention. So the last birth I attended was in November, and my client experienced this. She had an epidural, and the baby's heart rate tanked. And the obstetrician said, you know, your baby's not tolerating contractions anymore, so we want to recommend an emergency C-section. But I would say, you know, and I'm not a doctor. I'm not that kind of doctor. But a more accurate statement would be your baby isn't tolerating the cocktail of medications given, right? It was doing just fine with its contractions before. So now we have begun this feedback loop of crisis, and her birth did end in an emergency C-section. And C-sections, right, are proven to be more deadly for Black birthing people, right? If you take one thing away from this talk, I would say that I don't necessarily think that hospitals are killing Black women, but C-sections are killing Black women, period. So we can really think about medical technology within the schema of the manufactured medical crisis that is now childbirth, right? Which is always medicalized and always must be intervened upon, and through which pregnant people must be protected from their unpredictable bodies. What's more, the outlawing of granny midwives like Hill Coley in the 1950s runs parallel with the development of medical technologies such as the midsection monitor and anesthesia and the advent of the hospital birth. We have since seen a steady decline of positive Black birth outcomes. So as no official end has been noted of the Black maternal health crisis, right, we can purport, or I suppose it is still on the national agenda, a la Vice President Kamala Harris's announcements when she became Vice President that it was going to be her office's priority. I've not heard anything since. But we really have to continue to speak about this urgent overlap of emerging medical technological tools and how we can attend to the humanity of Black reproducing people in their development. So let's return back to my sister's coinage of the baby internet to see the status of the effects of medical technology in reproductive rights today. I would encompass baby internet as just one parcel of what we call femtech, which is the booming health industry in which apps, sites, and devices are targeted towards women and femmes. Of second-degree murder on the basis that her child was born stillborn, okay? So the incriminating piece of evidence that the prosecutors used against her was that months earlier, at the beginning of the pregnancy, she Googled the word misoprostol, which is the main ingredient in the abortion pill, right? Just one word. Miss Fisher was eventually released, but she subsequently says on her GoFundMe, this happened in 2017, she still has not been able to find work, because when you Google her name, it always comes up next to second-degree murder of an infant, right? She is also struggling with severe postpartum depression, again, because of the loss of her child. So making sure that folks like Ms. Fisher have literacy over data and health information is crucial because we never know how it's going to be used. In 2019, the state of Missouri was found to have spreadsheets of all the menstrual cycles of every patient who had ever been to their one Planned Parenthood in the state. And it is thought that they were aggregating information on profiles of people who might be seeking abortions in the next 10 years, right? So that when abortion is outlawed, then they have profiles of people who might want to get one. And as legal scholar Cynthia Conti-Cook writes that this is not unlike what the Department of Homeland Security did in the early 2000s when they created profiles of Arab Americans who they thought might commit a terrorist attack after 9/11. And so the redaction of our reproductive rights is imminent, but I don't want to speak abstractly here, right? There are people in jail for these things. It's not just imminent, but it's begun for a lot of Black women and a lot of folks, especially in the South and those from low-income backgrounds. So what I, a scholar of the cultural histories of Black reproductive life and our right to control our information, finds most provocative is how we might theorize the body and medical technology while undoing the rhetoric of crisis that especially surrounds Black lives and the vessels that contain them. I do this so we can unthink as a group here today, as a school, society, whatever that means, right, the inherent desire to use digital and technological tools to control Black reproduction. So we've all heard this adage that, these crises are nothing new, there's nothing that we can do, but perhaps, to think about it differently, to have a Black body is not to necessarily be in crisis, but to present a constant crisis to a society that denies our humanity through our physical manifestation. In 2020, in an op-ed for the Toronto Star, poet Dion Brand attends to this push and pull of materiality of crisis as she attends to the disproportionate rates of mortality amongst Black women who died of COVID-19 or who lost their jobs because of it. Her corporal rhetoric imagines for us how multiple bodies, body of the government, electoral bodies, and as she deliciously puts, the endoskeleton of the world, is all fundamentally anti-Black and constructs our individual oppressed bodies, right, and how we were treated during the COVID-19 pandemic. Her work inspires me to think of a popular Black American colloquialism, which is to be bodied, which can mean to be murdered. Thinking the Black vernacular as a theory for living, being bodied is an imperative. Our bodies must be materialized in order for us to expire. After all, one must be bodied to ever get attention from the very institutions that attempt to overdetermine our everyday lives. We must be sick, in pain, near death, or dead to become a statistic useful to the government or to be seen in our understaffed emergency rooms. It often feels as if to be embodied as a Black person is to simultaneously be bodied. The Black reproductive crisis, or the Black maternal health crisis, and the crises that compound onto and into the COVID-19 crisis cannot be detangled from the institutional and systemic ailments from which they are consolidated. Philosopher Anthony Bogues proffers a similar consolidation is true of American imperialism, which aims to, quote, consolidate its single truth as the only way of life, thereby affirming for us in itself that we are indeed at the end of history, end quote. A singular narrative is true of crisis, in which a story of the end is abrupt and inevitable. In the pandemics I've discussed today, it's very true that in the most literal sense, that some people have met their end via death, right? Again, I don't want to abstract that. Black people are dead because of these crises. It is paradoxical for those that we mourn that we are compelled to see that dying is not the only way of life. We are free to imagine beyond the strictures of crisis which demand our death, and that we first begin to demand materiality in its digital and technological forms to work differently for and by Black maternal bodies. Thank you.
Thank you so much. That was an amazing talk, and we have time for some conversation. So, questions?
You're cooking back there on that sofa, I see you. Go right ahead. Oh, yes, fine.
So this is, I guess, less of a question, more of a statement. I just want to thank you again for your presentation, especially having some background information about different, practices of medical racism is so interesting to continue to see and continue to know just how important this kind of research is, and just to continue to recognize its impact in creating change within that.
Yeah. Thank you for coming.
Thank you so much for the talk. I had a question regarding the emergency C-sections that you were talking about, and how it's not the act of birthing but C-section that's killing Black women. And even in India, in the last 2 decades, there has been a huge rise in the number of women going for C-section, and the numbers are just staggering. All the friends and parents and families that I know of are increasingly opting for C-sections. So I was wondering if you could talk a little bit more about the rise in C-sections and where that's coming from and how it's affecting um, not just black women, but uh, the larger landscape of what reproduction means and looks like for women.
Yeah, that's a great question. So I would answer this two ways. The first thing I would just note is that the overwhelming cesarean rate among Black women in the US are emergency C-sections, right? So those are things that when you come into the hospital, when you're in labor, you actually consent to immediately, that you will give, emergency, you'll defer to the hospital or the doctor if the term emergency is used, okay? And so that is like kind of a loophole as to how emergency cesareans occur, okay? And very quickly and without choice. And that's why, I feel like I'm having an identity crisis as a doula, because I don't feel with that organizational structure, that structural inequity, that I can do anything, right? They say that doulas are lowering the rate of emergency cesarean rates, but Black maternal death is up 70%, and we have literally now, like, I think 100,000 new doulas since 2020 alone. And yet Black maternal mortality has risen, right? So I would just make that note first, is that they're mainly emergency C-sections in the US, but I would say globally, I mean, C-sections have been popularized, especially since the 90s, because of their, the aesthetics of them. To be really plain and transparent, I've been in prenatal appointments where doctors like to talk about what having a baby does to your vagina, and how that's something that you don't want done. Kylie Jenner actually popularized, and Britney Spears did this, popularized choosing your baby's birth date based on an angel number. And C-sections are also really popular because of that. People want to choose their baby's birth date. I know in some cultures, I have read a lot of actually work from like Iran. They talk a lot about just the cultural mythology in general, about birth being terrible. And I'm not going to stand here and be like, it's super great, I've done it twice, right? It's like not my favorite thing to do. But there's also studies that storytelling about how bad your birth experience is actually can lead to a bad birth experience, right? And so rhetoric is really important here, and how a society talks about and the language used around birth. And so in countries where it's not something that's sacred, or it's really something to be dreaded, there's a higher C-section rate.
Thank you.
Thank you.
So thank you for your talk, really interesting. One thing that strikes me is that in certain, my wife's a physician and my best friend's a surgeon, and one thing we've noticed is that in other parts of medicine, what used to be 2 jobs, let's say 1955, which is doctor and nurse, the jobs that those 2 people had have now become somewhere around 15 to 17 jobs. You've got RN, LPNs, PAs.
Sure.
It sounds like OBGYN has sort of missed that trend, that they've kept this very close. Do you have a sense that that's part of the issue here, that whereas other doctors are willing to let other sort of subdivide the role, OBGYNs have not, for whatever reason?
I mean, that's really interesting, because we also have, OB and midwifery units that are working side by side in a lot of hospitals. At the University of Maryland Hospital, where I gave birth, right, OB and midwives are on the same floor, and actually, if it's your time to have a baby, you actually don't get to choose if you have an OB or a midwife, it's just whomever's on call. And I don't know if this answers your question, but I do really want to note, just to emphasize something I said earlier, which is that, OBs, I really wouldn't say are like also the categorical issue, because although it is a very hyper-medicalized practice, the interpersonal relationship with someone, you don't see your OB, right? If I'm at the University of Maryland, where I think they have something like 16 rotating OBs, you do not meet the majority of them. L&D nurses, right, are the ones who are in the room, who are knowing the patient. NPs are doing prenatal appointments usually. And so I would say in my experience, when I go to prenatals with people, the bulk of medical racism that they experience are by nurses or NPs, but not necessarily of the OB. And then also I would say to midwives, because just working, you can be trained in any type of practice, but working in a hospital and having to attune to some of the structural inequities that exist there, being a midwife doesn't mean anything.
A follow-up question, so I
Sure.
have two children. The thing that struck me when we had the two kids at Sibley in DC was that on our way out, they hand you a basket.
Mhm.
And it's clearly a very corporate gift, right? So before you even leave the hospital, 4 or 5 corporations have all chipped in to get you to kind of line up behind what they produce. You get any of that dimension here as well, that this is really a kind of brought to the surface, you've got a whole bunch of people trying to make money off this process?
Oh, absolutely. I mean, so if you use the apps, if you go use like babycenter.com is one, or What to Expect When You're Expecting has their own app now. When you put your email in, you also put in your home address, and you will immediately start getting formula samples in the mail. So I think I was like 1 or 2 months pregnant when I was just getting like formula sampled whole boxes. Because once you get your baby on formula, you never want to change the brand, and so it's the first to be in the baby's mouth. But no, I mean, hospitals have deals with Johnson & Johnson, and we know of the horrendous issues with Johnson & Johnson, and that became a corporate crisis for hospitals because they're like, well, we have all this inventory, and we've been telling families for decades that you need to use Johnson & Johnson. So are we culpable now, right, for all of these endocrine issues that are happening with babies that grow up to not being fertile themselves because they use the chemicals that were in Johnson & Johnson soaps? But yeah, no, there's definitely corporate wisdom to it. Sure.
Thank you.
You had a question in the back.
I did, but you might have already spoken to it. I was wanted to know if you could talk more about the relationship between like cultural and other medical staff and the possibility of I'm wondering if there's ever tension or anything that happens in the 21st century in that kind of relationship. But maybe you spoke to it earlier.
I mean, I could always talk more to that. I mean, tension, yeah, where do we start? So it's extremely tense. I would say that most of the work that I do as a doula, I'm not there as a doula, I'm usually as someone's friend. I'm someone's sister, because when I was living in Los Angeles at Cedars-Sinai in particular, you have to sign, they have like a doula 10 commandments. Like, thou shalt not intervene when the doctor's in the room, you can't speak over people. And if you don't sign that, you can't attend the birth. Whereas, if I'm a partner or a friend, then I can, intervene. So there's definitely tensions there. A lot of doulas don't want to sign pieces of paper. I mean, just in general, there's just an antagonism with doctors. They feel like it's just one extra person in the room. And you're also there, they see us as like kind of interventionists on the cover my ass, things that they're trying to do. And so they're trying to say all the right things, like, do you consent to the emergency C-section? And so when someone's there saying like, no, this is not what we talked about, obviously that's not, they can't get back to playing golf, as soon as they would want to, so that's an issue. Yeah, that's one example, sure. You have a question?
Yeah, I am curious about, trying to get my words together. So if we're thinking about the ways that like technology in combination with the rhetoric enact a kind of like surveillance under the guise of like safety, like we need to monitor, like the over medicalization. I'm wondering about if you've thought about how Black women are responding, perhaps with a kind of like counter surveillance or a countering. And I'll tell you what I'm thinking about. I'm thinking from like personal experience, my own healthcare and caregiving with my mother and grandmother, and the ways I remember there being like I don't know if it was a hashtag or a trend, something where people were recommending specifically to Black women when you request a particular kind of like intervention or test and somebody tells you no, you insist that it be documented on your chart and that then, will get you a different result. And I'm also thinking about a recent like TikTok that went viral, this white doctor that's like, Black patients are on the phone when I come in the room, but why do they do that? And then everybody shut him down, but like that very much is the practice in my experience in Black families. You don't leave your people in a hospital by themselves. You don't go to appointments alone. You know, I was a teenager with a mom experiencing breast cancer, advocating in a hospital. She was a single parent, like, because she's not gonna be in here by herself. So like, how Black people specifically like counter these kinds of like practices if you do want to stay, like you talked about people deciding not to engage with healthcare, not to go to the doctor. But if you do stay engaged, how do people like sort of counter surveil is the word I want to use, but I don't know if you have another way of framing that.
Yeah, so I mean, I think a way to answer this question is that, you know, the statistics, like I said, don't lie that this like crisis of Black maternal health is not necessarily getting better. But we do have effective evidence that says that, yes, I had this emergency situation, but I felt better about it because someone was there with me the whole time, right? Or like, they call it happy baby effect, right? Which is that you can endure violence in the hospital by an obstetrician, terrible things, but if your baby is healthy, then you remember the event as something that was positive, right? And so we have more of these outcomes where it's like, well, I don't necessarily, you know, am I happy about my hemorrhage? Absolutely not, but my baby is healthy and I remember my doula handing me my baby. Or it meant a lot to me when my doula asked everyone to leave the room. That's the last thing I remember, right? So, you know, there's also another tricky part about this work about, you know, just counter surveillance, and I guess it probably undercuts all of my arguments, but that, you know, having a doula costs a lot of money. It's not a free thing. You know, I lived in Los Angeles, doulas Black doulas were charging sometimes $5,000. And, you know, on the low end would be more like $800 to $1,000. And so having that person with you, even to just go to prenatals, if you can find a friend, is really, really important. Yeah.
I finally have a question, sorry. I was curious, I know we discussed a little about Missouri in the presentation, and you talked about some of your lived experiences, both in DC and Los Angeles. I was curious if there was any geographic connections between like more people using the apps in certain locations, or if there was any connection, specifically thinking of the South, to like be more transparent. I'm from Mississippi originally, so I'm thinking of the more contemporary issues around reproductive health and the ongoing restrictions, especially in southern states. And if you saw, did it lead to any, you know, more use in these locations, and did the maternity rate increase in these locations specifically, if that, you know, if that information was.
Sure, so in terms of demographic and social media use, I would say no, but I think there's a serious divide of age. So when I was working in Los Angeles, I was helping younger teen mothers, ages 12 to 18 or 19, who were having babies. And they were very reliant on apps, very reliant on everything internet, part of all the social media groups. I would say in terms of southern states, what's really interesting is, right, like this data is coming in with, you know, like abortion repeals and things like that, but we do have evidence of things that have already been outlawed, like home births, right? That's illegal in Mississippi. And we have evidence, actually someone was, I think they're actually probably, yeah, they're still incarcerated right now, because so they decided to hop the state line and give birth in a hotel in Alabama with a Black midwife. And you know, no one ratted on them or anything, but she sent a picture of her baby in the hotel. It was identifiable as the Holiday Inn, and it was from her personal Facebook message that they were able to incriminate her. And so in the South, there's a huge. That's why I'm also like very on the fence about birth photography. It's also a very booming field, and it's very beautiful and gorgeous, and we love the Insta photos. But it is absolutely evidence for home births in places where there should not be a home birth, or people who are having midwives or doulas and, you know, maybe aren't certified in that state through a specific licensure. So that's how I would answer that.
Time for maybe one more question. Anybody?
No one else.
There's one back here.
you mentioned during the talk this concept of the emotional archive versus sort of like the medical archive. I was just hoping that you could speak a little more about that.
Are you Will? Oh, okay. Someone was like, if you see Will and he's wearing a mask, tell him hi. What's my favorite? Non-Will. So I would actually say that this is kind of more of the topic, of my book project, right? And so when I talk about scraps, I'm really thinking about these parts of the quote-unquote archive that are not necessarily, seen as artifacts. And of course, we have like Alexis Pauline Goob's like documentation of Audre Lorde's dreadlocks. I went into the Toni K. Bambara archive, and she has like paper plates with chicken grease on them. It was like, this is from my favorite spot in Atlanta. Like, you got to get a load of this. And so I think, this kind of like interconnection between materiality and the emotional becomes completely disrupted for Black women and Black feminist creators. I absolutely love that. We can also see this in material studies with, hand-me-down of, we have Ashley Sack in the mock right now. This is really hard for me because I'm trying to pinpoint one example, but I just have so many juicy ones. Here's a good one. Okay, so in the book project, I talk about the Atlanta child murders, and I talk about, and actually Jershon's work was very instrumental in this, but of course. So I talk about how all the child victims have headstones, okay, except for one. And the mayor at the time, Mayor Jackson, donated the money for all of these children to have headstones, except for one. And he did not do the one, Eric, because Eric's dad at one point shouted the mayor down and made him look bad on TV, okay? And so I think we have like this Black paternal grief, we have this Black family grief that very much, it creates an absence, a material absence, but also is like, I guess, it's immaterial, right? Because it's also telling us something about this archive. Eric does not have a headstone, he still does not. If anyone ever wants to put some money, they should give Eric a headstone. But that's just something I think about a lot, right? Is that so much of what we find in the emotional archive appears materially or immaterially. And again, we can see it through these things like birth stories. There's a reason why a lot of like my Black clients are like, I'm not breastfeeding, and my grandma told me I cannot breastfeed around her, and I live with my grandma, so I will not breastfeed. It's like, okay, well then you come to find out grandma was a wet nurse, right? And so grandma does not want to look at breastfeeding because grandma cannot handle it. And so I think there's a lot of different examples of how, our emotions or how we feel about things in our bodies and reproduction in general, right, then kind of contribute to what we think are very white supremacist attitudes. Everyone should breastfeed, but it's like, no, this is a very Black thing that a lot of Black people want in their homes or in their communities, right? That answers your question.
Thank you.
Of course.
Probably could speak one more in.
One question that was, you used the word crisis, I found it striking.
Mm-hmm.
Sometimes crisis can have the sense of being temporary or an aberration, or not the normal. It sounds like you're not, in that sense, it's not a crisis, it is the normal. It is something that's becoming the state of what it is. So when you use that word, how do you think of it as the crisis? How do you define it?
Yeah, well, I'm wrestling with this because, again, I think that wherever the Black reproductive body is, then all of a sudden there's a crisis, right? Whenever there's too little Black kids, it's a crisis. There's too many Black kids, it's a crisis. It's a Black pregnant person, it's not like a monstrosity. I don't know what to do with that. I think that's something I'm always going to be wrestling with, and how we present crisis to different situations, I guess.
Thank you so much.
Thank you. Thank you.